Okay, this panelist is a combination of different people from Mwanza, Tanga, and Zanzibar. So our first panelist from my right side is Dr. Furaha. She's a surgeon from Sokoine, from Seketure, Mwanza. And the second one is Dr. Mariam. She's a radiologist at Lumumba Regional Hospital in Zanzibar. Third is Dr. Fadia Ali. She is a pathologist. In Zanzibar, we have a scarcity of pathology. We just have 2 pathologists, and the one is currently in ministerial level. So she's the only one pathologist currently working in clinical area. And she's surgeon by professional. Also, she's one among our team. The 5th one is Dr. Rashid. He's a surgeon from Bombo Referral Hospital who has many experience in breast cancer screening, treatment, and in management in general. And the last but not the least is Dr. Gertrude. She's an oncologist from also Bugando. So welcome all. Starting with Dr. Furaha. Can you demonstrate on clinical breast examination on CBE? Welcome.
Okay, it's my pleasure to be here. Good morning, everyone. My task today is just to take you through the clinical breast examination. And from my experience, I've been a general surgeon for almost 5 years now. And we have a lot of patients coming in the 3rd and 4th stage of disease without knowing they are sick. So I really have to take you through the CBE because majority of clinicians working in our primary healthcare facilities, they do miss these early symptoms of disease once patients are found in their health facilities, and they do misdiagnose them. So I can see we are part of the problem because we are making a delayment of being screened, confirmed, and treated. So if the client comes to you, because he's not yet a patient, it's a client, CBE is very simple. It's usually done by a health professional. Should be a skilled, healthy professional. And the way we do screen, the way we do our outreaches, we found a lot of patients are missed by the clinicians. So from our knowledge given from our medical school, take a note to update yourself. Misdiagnosis starts from us, not from the client or the patient. So this is just a way on how you can do the clinical breast examination. Clinical breast examination is the assessment of the chest, the breast itself, and the axillary region. The chest, I mean, how does the muscles and the breast structures looks like? This breast of mine is not normal. We really have to know our breast first. Then the patient or the client can give you also a clue. I have something abnormal in either side of the breast. You have to take a note on that. Precaution. Take a note and examine patients. Just don't listen and send for investigation. Examine them. The other part which is normally missed is the part of lymph nodes. We have several lymph nodes, superficial lymph nodes in our chest area and axillary region. try to your best to examine them. So, we have two different ways of taking CBE positions. You can ask your client or a patient of her waist, as you can see, and see the breast sizes and how they look like. Are they the same, or there is any abnormality seen from the picture number A? Then you ask your patient to raise the arm aside. You either to raise the upper limbs up, or as you can see from picture C, she can touch her waist and see how the muscles and the breast movements are. Are they normal, or any breast is lagging behind? And how are the muscles looks like? Or you can ask the client to grasp her hands upward. Then, afterward, you assess, are these breasts symmetrical? But we usually, left breast is larger compared to the right breast. Don't be confused about it. That's why you really have to ask your client, is these breasts yours? Do you know your breasts? Are they looks the same? As you all know. Then, afterward, you can ask your patient or the client to lie down. Then, you go straight for the assessment of the breast itself. The assessment of the breast, you will have to choose. Either you go clockwise or you go anti-clockwise. Do not skip. Use your palm. Don't pinpoint the breast. Always breasts are very sensitive, huh? Yes. So you palpate it either clockwise or anti-clockwise. Do not jump or miss any part. And the last, after breast palpation, you go and squeeze the nipple and see what is coming out from the nipple. Is there any discharge or not? Afterward, then you go straight to the axilla region. Very, very important. As we all know, most of the clinicians, we do know we have 5 groups of axillary lymph nodes. Then make sure you assess all of them. Make sure you assess all of them. Then you will ask your client or a patient to turn his upper limb either downward to her head, or that will be the very simple way for her while she is lying down. Then you start with inspection as usual. Some of the lesions of the breast starts from the axilla. You find the patient has nothing significant in the breast, but has an axilla mass. We do miss them, we do just call them lipomas. They are not. Majority of them, if you take them for histopathology, they tend to be breast lesion. Simply because of the lymphatic drainage of the breast, the way it is. Are we okay? Yeah. Next slide, please. So these are some of the lesions of the breast. As we all know, I've talked about the symmetry. The first picture shows the asymmetrical changes, as we can see. And the second picture shows the nipple. How does the nipple looks like? If the common and a normal nipple, it looks downward and outward. And it usually looks like a fibrotic. But you can see the picture number 2, the nipple is circumferential and looks like flat. That is suspicious. You go to picture number 3. There are changes a lot, but not necessary to be being suspicious of breast cancer. We have several lesions of the breast. We have benign diseases and we have malignant diseases. Also, we have skin diseases in the breast. So, picture number 3, the areola looks like the way it is, but it's common to be a Paget eczema-like. Then, picture number 4, 5, number 6. These are typical changes of stage 3 and stage 4. But what to do next? We don't rush for mastectomy at these stages. We have to downgrade the disease first. So you really have to send your patient for neoadjuvant first after confirmation of the diagnosis. And this is where Pfizer with Ministry of Health and Jhpiego have been struggling a lot for us to go for the outreaches and perform our triple assessment at the SIMSIT and take these patients for the proper treatment. But also skin changes like dimpling, nodule, ulceration, pure orange, these are not all patients should present with all these. Patient might present with 2 or 1 symptom in the current visit. But we have some symptoms which are explained much for metastatic disease. Things like cysticercosis nodes. I think all we know about cysticercosis nodes. They do found around the umbilicus. So once you have come across with cysticercosis nodes, think about the disease metastasis. So your patient is at higher risk of disease advancing. Next. Okay, so all in all, I've been taking through the clinical breast examination, but we do acknowledge these people, Jhpiego, through Pfizer Foundation, and the Ministry of Health. From our site in Mwanza, we had a lot of clients coming for screening, and we have a lot of patients found with benign lesions which are treated, but our target is still on breast cancer. We have several patients met, and yet they are still on oncological treatment current for the past 3 months. And we have a major surgery, almost 6 mastectomies, and these patients are still on treatment currently. Thank you so much for listening.
Thank you very much, Dr. Furaha. Okay, Dr. Furaha is... Dr. Furaha is a surgeon. Okay. Can you tell us for how long does it take to train the healthcare provider about the CBE, and where actually these services are provided, maybe in Mwanza?
CBE, to start with the provision of the CBE component, CBE is performed at the primary health care facility. It's quite simple, and it's just for those who don't have skills before. We might take 15 minutes, including demonstrations on how to perform it. Because for those clinicians, it will be like a revision. But for the new ones, it's a new thing, but it's very simple. Can even done by a nurse or anyone who is a health profession.
Thank you very much, Dr. Furaha. Welcome, Dr. Mariam. So, Dr. Mariam, can you tell us in 10 minutes, just be fixed with time, can you tell us the benefits of breast ultrasound and the indication of early detection of breast ultrasound?
Okay.
Thank you very much. My name is Dr. Mariam Abdallah Ali, radiologist. I'd like to acknowledge the program that we're working in of early detection of breast cancer, supported by Jhpiego and Ministry of Health, and founded by Pfizer Foundation. This program have helped us to reach many clients that we in the outreach and being able to diagnose them using ultrasound. So what I'd like to talk about the imaging, the standard screening modality for early detection of breast cancer is mammogram. Because in mammogram we can pick calcifications, microcalcifications, which are early signs of breast cancer. But because of the limited resources in Tanzania, then we cannot send everybody to do mammogram. Therefore, we try our level best in this outreach to reach those symptomatic patients and do ultrasound and help to fasten the treatment and diagnostic processes. So, for ultrasound it helps because it can pick lesions that can be missed in the physical palpations. It can also, we use ultrasound also to differentiate benign from malignant lesions, because in ultrasound we use BI-RADS. What is BI-RADS? BI-RADS, this is breast imaging reporting and data system. This BI-RADS is used to standardize the reporting system of the breast imaging worldwide. In BI-RADS, what we do, we check on, for the case of ultrasound, because we can use BI-RADS in ultrasound, in mammogram, and also MRI. But in our case, for ultrasound, what we check is 5 things. The lesion. We have the lesion. What is the shape of that lesion? That is what we check, yeah. What is the shape of the lesion? We also check the margins of the lesion. We check the echogenicity of the lesion. We check the posterior features of the lesion. And also we check the orientation to the skin surface of that lesion. So BI-RADS, it helps us to categorize this lesion into those of benign and malignant, and hence reduces number of unnecessary biopsies. So I'd like to show you the features of BI-RADS2, which are benign. These benign lesions, they are mostly round or oval in shape. They have very circumscribed margin, as you see over there. The margin is very circumscribed. And also, most of them, they are parallel to the skin surface, meaning they are more wider than taller. And they show posterior enhancement, because the sound waves produced by the ultrasound, all of them passed through the lesions and nothing is coming back, so they produce posterior enhancement, that white shadow you see posterior to the lesion. And also, as I said, they are mostly very circumscribed, and most of them, if you apply color Doppler, which we find in ultrasound, most of them, they do not have flow. But for the case of suspicious lesion, which are mostly BI-RADS 4, 5, these lesions, another slide please. Yeah, this lesion, they have irregular shape. They are irregular. As you see, all of them, they are very irregular, speculated margins, some of them. The margins is not well circumscribed. And we see that they are hypoechoic. Why? And they show posterior shadow. All the images, they have posterior shadow because the sound wave produced by the ultrasound, when they pass, only few of them returning back, because these cancerous cells, they are very dense. So they produce shadow posterior to the lesions. So if you see something like this, irregular shape, non-circumscribed margins, it has hypoechoic echo texture, and sometimes when you apply color Doppler, it peaks slow. It peaks a lot of blood supply. So they are BI-RADS 4 or BI-RADS 5, and BI-RADS 6 is proven cancer. Yes? Thank you.
Dr. Fadia. Okay, Dr. Fadia, she's the one but also we had Dr. Mosha from Muhimbili National Hospital, also the one who helped with Dr. Fadia in our team. So, Dr. Fadia, can you maybe demonstrate on how to do the fine needle aspiration? Example of fine needle aspiration. Thank you very much. My name is Dr. Fadia Musa Ali. I am anatomical pathologist at Mnazi Mmoja Hospital, and hence now we are in PPP. I am currently a consultant anatomical pathologist at a Lung Center Laboratory. So, as a pathologist, my role is to perform fine needle aspiration cytology so that we can be able to identify those suspicious lesion, benign lesion, and malignant. So let us see on demonstration how the fine needle aspiration cytology is performed. Thank you.
Hello, I am Dr. Fadia. I am an anatomical pathologist at a Lung Center Lab and also pathologist from Mnazi Mmoja Hospital. Today I will demonstrate on how to perform FNA cytology. So normally when a patient comes into our clinic, she comes with the investigation form that explains to us the site of the lesion. For example, at breast, which side, is it right or left? So we will take a short history to know the duration of the disease, if any investigation that has been done before or any results that was given to her before. Then after that, I will explain to the patient the procedure, how I will perform the procedure, because this is a minimal invasive procedure. So she has to know what is going to happen, and then I need her consent. After getting the consent from the client, then the client will lie on the bed while she takes off the clothes and expose the site where the lesion could be visibly identified. I will palpate, make sure that I will get the proper lesion. I will aspirate the material. After aspirating the material, I will smear into several slides, and then I will fix it in the alcohol 80 to 90%. Then they will be ready for other procedure to be followed in the lab. So this is how we are performing our fine needle aspiration cytology. These are the equipment that will be used in our procedure. We have 21 gauge syringe. Also we will be using the frosted slide for keeping our material, and then we will put into the alcohol as a fixative. This is a 90% alcohol. After doing palpation, and we have already identified the lesion in our patient, and we know all the characteristics of our lesion. So we swab the area. Is it normal? Okay, then we are taking our syringe. Remember we have said we will use 21 gauge syringe, and sometimes we can have a gun. We can use a gun so that we can hold the syringe over there. But here we don't have a gun, we will use the syringe alone. So we take the curb, and then we stabilize our lesion between our two fingers. So you put your finger like this so that you can keep your lesion stable, because some of the lesion in the base, they have a characteristic of moving around. So in order to avoid this, so that you cannot get the targeted area, so you need to stabilize your lesion, and then you put your syringe perpendicular, and then you will start to aspirate like this while you are applying a little bit negative pressure, and then make sure that we are taking this several areas, and you will see the materials are filling in. You will see them, they are coming through your needle hub. So after getting enough material, so you remove the syringe and you tell your mother to apply a pressure so that to avoid bleeding, and then you will cap your needle, and then we are taking to prepare our smear. After getting our cytological material, we put into our slide so that we can make a smear. We apply a little bit pressure, and then you put. So yes, we are making a smear. And then after smearing, we are fixing into alcohol. After dipping our cytological material into our 90% alcohol, we normally wait it to be fixed, and normally it takes about 30 minutes to 1 hour, or you can even fix them more, it depends, before to be taken to the purple stain. Then we will take these materials to our cytological lab for other preparation. So this is how we normally or routinely performing our fine needle aspiration cytology. Thank you.
That you did for fine needle aspiration. And as we know now, like we are working together, majority of our hospital, especially district hospital, we are outsourcing some of the treatment and radiological. So, and on this project, we are working together with the Lancet. So can you explain how our collaboration with Lancet for this biopsy? Thank you.
Thank you very much, Dr. Camelia. Let us start with what are the targeted group that we can do the fine needle aspiration. Remember, our approach is a single approach visit. It means that after CBE, the ultrasound and the fine needle aspiration. So any woman or a man who can be identified with a lesion or a lump during CBE is required to do fine needle aspiration so that we can rule out is it a benign or malignant. Not only those who have a lesion, also we have some of the women who has a nipple discharge. We have to rule out what are the causes of the nipple discharge. So we are taking it cytology without applying, because fine needle aspiration, it means that we are applying pressure to take out the material. But when we do cytology for the nipple discharge, we take as it is, and we have to see cytologically what are those factors for them to have a discharge. Some of them you will find them as inflammatory, so they can be given only anti-inflammatory drugs so that it can disappear. Or there are some of the lesions like papillomatous lesion of the breast. Most of them, they are negative on CBE with a lesion. They presented with no mass. Even in a mammogram, you cannot find a mass. You can only pick through cytological material, and they have this is a papilloma. So also we have several benefits of fine needle aspiration. As we have seen our video that it is a rapid. You can do a test, within a day you can get a result. If you have a suspicious, you can rule out your benign or malignant. It only takes 30 minutes to 2 hours for the material to be fixed, and then you can review through the microscope and to tell is it a benign or malignant. So it is easy for the clinician. Another benefit is patient friendly, because it's a minimal invasive procedure. You can just explain to the patient what I will do to you. You will feel a little bit discomfort, but it will disappear after we are finishing the procedure. And also it is cost effective. Through Jhpiego, we are able to conduct this through our outreach, which of the things that we couldn't do it before, because we have a lack of pathologists in our setting. I am the only one pathologist in Zanzibar. So there are people who
Can you summarize?
Thank you. So there are people who are in need on this particular service, but they cannot be reached. So through Jhpiego, we go to different areas such as Pemba. We have been in Kojani, where those people over there got this benefit, where I have been able to perform fine needle aspiration cytology, and we have been able to identify those with a lesion. And also, you have also asked the question about how we collaborate with our partnership. So we are good on this. I'm working with the Lancet. So we are in a good term and condition and everything, and we make sure that all the services are provided. And also, I thank the Jhpiego by giving me an extra supporter with the pathologist from mainland known as Dr. Mosha, but unfortunately, he could not be here. We can use the fine needle aspiration cytology. Sorry, Dr. Camilla, 1 minute. We can use the fine needle aspiration cytology. We can take this and fix in the solution known as a buoy. So this, when you fix into a buoy, it creates like a biopsy. So when you have this material, will be two advantages. First, for the oncologists, they need to know the prognostic marker. So for this, we can do the IHC, the ER, the PR, and the HER2, and together with KR67. So they will be able to know the prognostic marker and also the targeted therapy for this. Thank you.
Thank you very much, Dr. Fadia. Thank you all the panelists from the second session. I welcome Dr. Slim, the Director of Preventive Service in Ministry of Health, Zanzibar, to continue to moderate the last session.
Thank you, Camelia. First of all, we need to give a right hand of the applause for the presenter that has really given us more insight about the clinical finding. I must admit, it's a privilege to see a colleague from Zanzibar actually feel more empowered in doing what it was a really good presentation, so thank you for that. Let's continue. We're proceeding to Dr. Manabaraka Saleh. You are a surgeon. Within 5 minutes, how can you tell us about your experience on breast cancer at Nazimoja Hospital? And then, obviously, you treat patient, and normally those patients that you normally come encounter, normally they're at what stage? But also, can you tell us how much it costs for them patient to be treated, and how is the treatment outcome? They are all for you. Good luck.
Good morning, everybody. My name is Dr. Manabaraka from Nazimoja Hospital as a surgeon, but I'm also the member in Jhpiego in case of early detection of breast cancer. Actually, after the patient coming with the cytology result, we usually go for tissue biopsy. As you know, we have to confirm before doing anything. So what we do, we can use core biopsy or to cut biopsy to get a tissue, then we send back to histopathology. After the results come, before decision of any surgical or any other intervention, we have to stage the patient. Work out on metastasis issues. We do CT, brain and chest and abdomen, so that we can stage the patient. So for the patient with early stages of the disease, stage 1 and 2, we usually do mastectomy alone. If the patient came in stage 3, that is advanced stages of the disease, we usually do mastectomy with axillary lymph node dissection, of course. Then we send the patient to oncology for chemo and radiotherapy. Usually the outcome immediately post-surgery is good, though we have some few complications like seroma formation, of which we usually manage them well. After some time, they get improved well. The problem is that in our setting, most of the patients came in advanced stages of the disease, that is in stage 3 and stage 4. So in stage 3 patient, we do mastectomy, then we send for oncology care, chemotherapy and radiotherapy. Stage 4 patient, we usually send them directly to oncology to get oncological care. So through the Jhpiego, With collaboration with Ministry of Health in Zanzibar, we were able to reach a huge number of the people during screening, whereby we screened more than 5,000 people. Of them, we got like 15 cases that were confirmed to be breast cancer invasive, but all of them actually were in late stage, in stage 3 and stage 4. So we did mastectomy to those patients and now continue in treatment at oncology. Based on the question, what are the costs? Actually, policy of Zanzibar, the medical care cost is actually free for all patients, surgically and medically. So there's no cost to any patient who come to our service. We saw them at the community level, we send them to the facility level at the referral hospital, and they get medical care for free. The outcome is depending on the stages of the disease. So for us, surgery, immediate post-surgical care and outcome is good, but at the end, the outcome for the survival of the patient will depend on the stages. For those having early stages of the breast disease, actually the outcome is good. For those presenting in late advanced stages or metastasis, the outcome will depend on how the progression of the disease itself.
Thank you very much, Dr. Mana Baraka, correct? Yeah, thank you very much, but we're coming back to Dr. Rashid. Dr. Rashid, obviously you are a regional surgeon from Bombo Referral Hospital, which is in Tanga. Within your 5 minutes, can you tell us what are the key challenges that you have experienced as a surgeon in early detection breast cancer program and mitigation strategy? Please go ahead. The floor is yours.
Thank you. Good morning, everyone. As a general surgeon from Tanga Regional Referral Hospitals, I have an experience of over 8 years in doing the breast surgeries. What I can count is almost like I can say more than hundreds breast surgeries. So what are the key challenges we have seen during seeing these patients? The first one is cost. In terms of in millions, as we know, the health provision service is not free. There is a cost sharing, the issue of cost sharing, which is in contrary to Zanzibar. We know the service here is free, but there the patient has to contribute to something in the starting from the investigations, going to the times of surgeries, but also after surgeries has to go to the further treatment if is needed for those who are in stage 3 and above. So coming to that question, Dr. Slim asked Dr. Munabaraka probably will be the best for mainland because we are in cost sharing. So what are the average costs? This cost in terms of diagnosis, during early diagnosis, it can range from 100 to 150 shillings just to confirm the diagnosis. But after that, you may need the cost for surgery. The surgery usually depending on which level of the hospital you are working, but from the level of the regional hospitals in Tanzania, it's usually range from 300 to 450s. So add 150 from 300, but then probably this patient may need more in treatment. So may need more treatment, you have to send the patient for further treatment. So probably it can range roughly from 500 to 700. So the cost is one of the big challenges we are facing for the patients. Usually most of our patients who are attending, we know they are poor. Some of them they can't afford even completing the investigation, the basic investigation to confirm the diagnosis. So this is one of the major challenges. So what is the mitigation of these challenges? For this case, the family support is very important to help the patients who have breast cancers. We can see our cultures, we can contribute a lot in ceremonial issues, but when it comes to the issue of health, the people that run away from helping their relatives, then it's a close relatives, just a very few cost which can help the patient. So this is one of the big challenges we are facing in Tanzania mainland, specifically in Tangas, where is the second or the first regions in Tanzania mainlands with the most, with a lot of patients with the breast cancers, as it is included in this program. So that's one thing. But another mitigation in this issue of cost, we think the universal health coverage could be the important pillars to help maybe these patients who don't have an insurance, they can have an access in the treatment. But that's the first challenges which is mainly we are facing when we are counseling these patients for surgery or for further investigations. Another challenge is we are mainly facing when I'm seeing these patients is the distance. You know, based on our data, more than 80% of the patients are treated at the primary health cares, which is usually the dispensary and the health centers. But at least to be able to confirm the diagnosis, you need at least to be at the level of the regionals. It's where we can do most of the important and confirmatory diagnosis on the breast care. So seeing these patients, they are coming from far away from the dispensaries. So it's a big challenge. Some can tell you that I don't have even the money for the transport to the region. With my experience from Tanga, when you come from a far village like Kilindi or Handeni, you can spend 8 hours to reach the regional hospitals which I'm working, where at least you can do and perform all levels of investigation and treatment to the level of surgery. So how many? 8 to 9 hours. So it's far from there. So what is the mitigation in these challenges? What I can see mitigation in these challenges is the capacity building to the lower facilities. The team which is there, we know most of them, as my colleague has said, the basic clinical breast exam they don't know, or they're not really sure how to confirm how at least this patient has a lesion or not. So as one of the target of this project funded by Pfizer Foundation and Jhpiego is to create awareness, is number one target, to create awareness to the facility and capacity building. So the capacity building, this is in terms of the healthcare workers, but also in terms of the facilities to the lower level. At least when they can have a knowledge on how to diagnose the patient in the early stage. But another challenge which is big is psychological torture to the women, because women, they don't want the breast to be removed for sure. We can make all the efforts to make the diagnosis, to counsel the patient, but they refuse. And we are getting a lot of challenge on these patients because we confirm they are having a breast care which need to be surgery, but they don't want to be removed their breast. So I think this is because of the beliefs we are having on our communities, that the community, the issue of stigma, when they have a breast cancer or the cancer, I think the stigma is a big issue. But also the relatives and the friends and the families. Without our family looking a lot on the families, listening to here and there, without listening to the professionals working on cancer. So we are really faced these the main challenge. So in the mitigation issues of psychological, it's just we sometimes involve the psychologist in the counseling of these things. Thank you very much.
Thank you very much.
Yeah, thank you, Dr. Camilla. Thanks, Dr. Rashid. I know we are Rashid, right? Dr. Masashi, you are an oncologist from Bugando Medical Center. Please please tell us briefly what are the treatment modality of confirmed breast cancer in your institution, and what are the key challenges that you have experienced in breast cancer treatment in space? Thank you.
And colorectal cancer. So, management of breast cancer includes surgery. We move from mastectomy is confirmed. We have to stage the patient. We know the stage of the patient because we are treating the individual, not the disease. Different patient, they have different, same patient of breast, they can be treated differently. So, after you can do surgeries, we have chemotherapies, and these have been offered at Bugando, Ocean Road, KCMC, Benjamin Mkapa, and several centers at Dar es Salaam. Also, we have, after the patient have completed chemotherapy, we have radiotherapy, and in chemotherapy, these patients receive like almost 6 to 8 cycles, and every cycle is after 3 or 2 weeks. And the cost of each cycle ranges from 200,000 Tanzanian shillings to 600,000 Tanzanian shillings. So you can imagine how much it costs. Every after 3 weeks, the patient has to come for chemotherapy with this disease. After the patient has completed radiotherapy, it's almost 6 to 8 months. The patient will be subjected to radiotherapy. We give radiotherapy to prevent local recurrence of the disease. And then we have targeted therapy depending on the histology of the patient. For those who express estrogen receptor or the progesterone receptor or the HER2 receptors, we have targeted therapy for that. So the patient will undergo targeted therapy depending on the characteristic of the disease. So for those who express or PR positive, they will be treated with a tablet for up to 5 to 10 years. The patient will be taking a tablet every day for 5 to 10 years to prevent recurrence of breast cancer. Again, we have targeted therapy for HER2, also targeted therapy for those patients with BRCA mutations. Thank you. So those are the brief explanation on how we treat breast cancer.
Thank you very much, Dr. Shashi, and I think from the panelists here, most people on the floor have gained insight on the prevalence and cancer, but most importantly here we discover that the earlier we picked up, the quicker we get the solution out of the way, and it's even less cost to manage it. And there is a contrary between Zanzibar and mainland in terms of cost sharing. So people of Zanzibar, you really have to appreciate the way that at least when you are ill, your finances is not part of the problem. Yeah, and that's something that we really have to be proud of, but also the importance of universal health insurance for everybody, because that will make sure that everybody get touched irrespective of their financial institution. We embark on the psychological issue, stigma associated with breast cancer, especially when they require high intense surgery, etc., etc. There is a very important element of awareness here. People are showing up really late. People are showing up really, really late. So early seeking behavior is very important if we really have to reduce the burden of this disease. I will now go back to the managers who are really chairing for these two programs. One is Camille, obviously she is under my custody, and another one is Dr. Safina. Yeah, both of them. Sorry about that. I'm trying to get to know you better, right? So, from what we've seen here, what can you advise the government? I'm talking about what can you tell about policyholder in making sure that we sustain the privilege we've been given by the foundation of Fraser and Jhpiego in relation to managing the whole scenario of breast cancer in Tanzania. Karibu sana daktari.
Thanks very much, Mr. Moderator. As he said,
Dr. Safida Ayuba from the Ministry of Health, mainland Zanzibar. For what we as a government, what we are going to sustain for the what Jhpiego introduced, we are going to strengthen for mainland. We are going, because we have a demonstration region 2 region, we are going to strengthen and then scale up to other region. But also I want to advocate for allocation of funding, and I will see we are targeted to see 60-68, so we need to promote allocation of funding so we can maintain what we started with Jhpiego demonstration of single visit approach to do all these things together. One thing is the integration of the service. We know these women are coming to the different area of the clinic in the facility, so we need to integrate the existing other program for reproductive health so we can reach more women. Remember, these are normal women, they are not diseased, not yet. So we advise to have integration of service in the family planning, cervical cancer screening, as we do in the mainland. As well, I can, as a panel say, there's the issue of the costing. We know there's the cost of the diagnostic and the treatment. For the mainland, cost of diagnosis is still incurred for the family, so we need to engage community as well, especially family, to own the other cost for the diagnostic and the treatment, because this is a long way to go when you have a diagnostic for cervical, diagnosis for the breast cancer concern. And then we continue to capacity building to receive the knowledge of gap among the health workers, so we need to capacitate, going on to capacitate healthcare workers, especially for the first who see the client, so we can minimize the early detection, or we promote early detection for the client. Thank you.
Thank you. And now same approach to Dr. Camelia, please.
Thank you very much, moderator. I'm Dr. Camelia from Reproductive and Child Health Program. I would like to acknowledge Jhpiego and Pfizer Foundation for this invaluable support for this project. So as a government, we have a different intervention to make sure we sustain this project. Firstly, we engage different specialists, as you can see, from the beginning of this project during the development of a guideline of breast cancer. We didn't have a guideline of breast cancer. So during our development, preparing of materials, we involve like a surgeon, Dr. Mwanabaraka, Dr. Fadia, Dr. Mariam, and Dr. Salamauledi. Can you please stand up? This is our oncologist from Zanzibar. She's one also among our team during all this project from the beginning until now. So we also have capacitate healthcare workers in 2 districts in Guinea and Kaskazini A. And in future, through collaboration with ministry and other stakeholders, we plan to strengthen to other districts from North, Pemba, and South in Unguja. So also we, through Jhpiego, from next month, we plan to capacitate the surgeon, pathologists, and other general practitioners in district hospital and regional hospital on doing core needle biopsy. As we know, like we only now have only one pathologist that did fine needle aspiration. So we thought by doing this capacity building through surgeon and the general practitioner about fine needle aspiration and core needle biopsy, it can help us on early detection of during the diagnosis on this management. And coming to the ministerial level, in next year, we expect to construct a large center for Cancer Institute in Zanzibar, because majority of our patients, we just have a chemotherapy in Zanzibar. We don't have a radiotherapy. So we send our patients to radiotherapy in Ocean Road, and as we know, costs. So majority of the patients, they don't go, when we send to Ocean Road, they don't go to Ocean Road. They end up staying in their house, and they come back to the hospital just in palliative care. So by constructing this center for cancer, we will have all like chemotherapy, radiotherapy, and other management, so it can help us to relieve this burden of disease and the death of our patient. Thank you very much.
Yeah, thank you very much, both of program managers. I think now it's up to the floor now to ask any question, and then for the panelists to collaborate in answering them. Thank you. So we pick 5 people. 1, 2, 3, 4, 5, 6. We got 6. That's enough. So
my name is Jhpiego from Jhpiego TCI project. Thank you all the panelists and specialists for the colorful and wonderful presentation. I have 3 things to ask. Number 1, now we see like there is a big group of women, majority of them, they want to do artificial surgery for their breast, whether to enlarge them or to reshape in order to look nice and pushy. So do they put themselves into risk, and to what percentage? The second one, for myth and misconception on the social medias. Every single man now believe when they suck the breast of lactating mother, they reduce the risk of getting breast cancer. And last one, for a man, engagement, because we have seen how women are oriented on how to do physical examination on their breast. How do men are involved as well to take care of it? Because today we have discovered that there is one breast which on the right side is larger than the left side, so we want to be part of it. Thank you.
Thank you. Can you answer first, then you go for the next? Anyone? Okay, we can take all the questions, then they can respond.
Asante. My name is Dr. Mugisha Ntonzo Nkoronko, General Surgeon and now the President of Medical Association of Tanzania. I would like to acknowledge the presentations. They have touched a very, very important things within the breast surgery field. But they have, I know it's because of time, not by omission, they have forgotten a few things that I would like to add. Number 1, we do have male breast cancer, and the number is increasing. They should be included in early detection of breast cancer. Number 2 that I want to underscore, this country has got over 61 million people. Up to now, we have data that we have at least 51 or 52% of the entire population being women. And breast cancer is the second largest breast cancer disease in our country that affects this greatest population. If you integrate economy, contribution of women, and what do we give back as healthcare providers to them who fuel the economy of this country, we are not balancing the equation. More women are suffering and more women are dying of this preventable disease. I'd like to ask that we include prevention during early detection. Any patient with a suspected breast cancer in his family or her family, there is a chance, over 40% chance of developing breast cancer for other members within the family, according to Gail model of risks. So when you see someone who is getting breast cancer at the age of 50, the primary member who will follow into that genetic pattern will follow to have at least a breast malignancy 10 years younger. So if we don't inform and engage the family, we will detect one and leave the rest in the family tree that will later 10 years develop breast cancer. So I think this is important time that when we are doing early detection, we also do early prevention of breast cancer. And number 2, we should now, I think Jhpiego and the other partners, including the ministry, they should be advocating for those with, because the trend now we are seeing in Tanzania, we are seeing I think the pathologist may be a witness to this. We are seeing triple negative breast cancer disease. These are the patients that are difficult to treat, and they have early recurrence within the first 5 years of treatment. And we are seeing patients now below menopause. This disease is perimenopausal and postmenopausal, but now we are seeing below the menopause age. So during the reproductive age, I've seen breast cancer in pregnancy, and it is very difficult to manage. Therefore, I ask that we include those things when we are looking for this early detection. Thank you very much.
Yeah, I think we have only 5 more minutes, so we can hardly use 4 minutes for a question. Be brief and concise, and then we wrap up and go. Right?
Dr. Kaloko, physician from Buganda. I'm just curious on the what is the government's position or investment in terms of research?
Because without research, we are only
I want to know the government's role in terms of budgeting for research in terms of prevention, diagnosis, and treatment. Thank you.
Thank you very much. I'm Marsha Makatayambi from the UN Global Compact Country Office. I'm looking at it in the perspective of the SDGs. And this is particularly on the SDG 3, where we're looking into ensuring that at least we reach 50% of our targets by now. But as we know, the targets are only at 17%. All I have been hearing here has been on the top down. What are our strategies in ensuring there is a bottom-up approach, particularly in equipping women and men particularly, in ensuring that they're able to do their own screening, and this is to use the very many assets which we have in the community, including the pharmacists, because once these women, they walk in, and men, they see even those photos which you had, the pictures on how to do their own screening, we can fuel these early detections at home. Because when we wait for them in the facilities, it will be far too late, and ensuring that we link the aspect of ensuring that the families, once one is detected, the whole family gets to be also moved to the level of detection, the triple care or rather approach which you have. I think we can do better by 2030. Thank you very much.
Thank you. My name is Ghalib Kasim. I'm an intern doctor at Mumbai National Hospital. I have a question towards the surgeons. How do you streamline to ensure that the patients that come for breast conservative surgery have their masses taken for histology? Because there are some patients that present early for breast conservative surgery and later come with the advanced stage disease with no report of histology. Thank you.
Okay, you just answer whatever they ask, and then we wind up quickly. A minute each.
Okay, thank you. I'd like to answer the question like sucking the breast is protective for breast cancer. We encourage women to breastfeed at least 2 years to prevent breast cancer, but not men sucking their breast. Also, in this program, through we encourage women who are breastfeeding to at least breastfeed for 2 years, but not men sucking women's breasts during breastfeeding.
Did you hear that? All right.
In Tanzania, the prevalence of male breast cancer is higher compared to the worldwide. In Tanzania, it is 6.5%. So through Pfizer Jhpiego, in this program, we involve men and women to come to screen and know how to examine their breast, to do how to do self-breast examination. When we teach men, he can examine his wife. So we also involve men. Also men get breast cancer. And
Okay, thank you. I will respond to some of the questions very fast. The first question is concerning about the artificial surgeries, the increased risk of breast cancer. In terms of research, we don't have really data, but breast surgeries which are conservatives can increase the risk. But usually, if you look on one of the risk factors of breast cancers, is doing previous surgeries, but it's not counted as the plastic or what we call the reconstructive surgeries. Another question which I can respond is Dr. Mugisha is concerning the early menopause and seeing the patient with breast cancer. It's true, like 3 weeks before this event, I have operated 26 years females with stage 3 breast cancers. So it's true that our target is about 35s, but we are seeing several patients with breast cancers below 30 years. That's completely true. Also, the issue of early detection and prevention, and that's the target of this program. That's to increase, to create awareness. The main issue here is awareness on the communities and came with early stage and diagnosed with late stage. That's going to happen because some of the doctors, they can do surgery without sending the tissue for storage. So can I give my other colleague to finish?
Okay, I would like to comment on the ages and diagnosis. I personally operated the girls of 18 years old with stage 3 breast cancer. That is very true, that currently we are discovering the breast cancer in very early ages. So based on involvement of especially genetics for those families discovered with breast cancer, I think this is the very important point of which I think the government through their expertise has to be involved, though currently through this project, while we are doing screening, we are trying to educate or training the individual client how to do self-breast examination on their home. So we are telling them, we are training them how to do SBE, self-breast examination, but at the same time we usually ask them to give education to their family members.
Thank you. I would like to respond also in a question that was asked from ASCGs. So we normally, on doing CBE, we give them education on how to do themselves. We are encouraging them to look their calendar of the menstrual cycle on day 10 or 11. So monthly they have to conduct their self-breast examination. And also I would like to comment on the question from Wimbili, who said that some of the surgeons, they continue with their management without histological report. It's still challenging. Sometimes we have a surgeon who are not bringing the histology tissue to the lab. I don't know why. So most of the people, they don't have their results. So you will see that the surgeon will proceed with the other treatment because the knowledge of knowing the importance of biopsy is still low because of the low pathology surface in our lab. So we still need to encourage government to emphasize young doctors to go and pursue the pathologist because this is a scarcity to us.
Thank you, Dr.
As an addition point on breast conserving surgeries, we surgeons, we normally do lumpectomy, quadrantectomy, but we don't make enough follow-up on the tissue sent for histopathology evaluation. This patient came back with an advanced disease because we didn't even orient the pathologist on the sample taken, and the pathologists, they do fail to give us about the marginal assessment. If you are going to miss the marginal assessment results, it's where this patient comes with an advanced disease. So I do advocate all clinicians who are performing surgery, not only surgeons, even medical practitioners. They do lumpectomies a lot, but you really have to take for histopathology evaluation and request for marginal assessment. Thank you so much.
Thank you very much. So shall I just close? A group photo first before we close? What do we do? Close first or group photo? Yeah, let me just close it.
I just want to answer one question.
What do you want?
Okay, I just want to add one question about the SDG. And on this project, this is a bottom-up project because from the beginning of our implementation of this project, we involve community leaders, especially CHW. And during our outreach program, the CHW are the one who are going to create awareness and bring the people to our outreach areas. And also we involve the sharers, all the community leaders during the implementation of this project. And we involve even the survivors. We had several meetings with survivors, and we ask for their support to create more awareness in the community. Because by having community area, I'll give you the example of those survivors, like you have a breast cancer disease, gait management, and surviving through all difficulty, we can get more empowerment in this process. Thank you. You can close.
Yeah, thank you very much for the panelists for such a very profound insight on cancer detection and also management, especially on breast. We have, in this session, we have learned a lot, especially the circumstances around management and the costs effect on the implication of the outcome, but most importantly, area of male breast cancer and how advise men in relation to taking care of their white breast, especially during the breastfeeding moment. The mission here was to follow the 60-60-80 protocol, and that will help us to really manage this disease very well. Some papers have suggested sub-Saharan Africa seems to have less prevalence of breast cancer compared to global west, right? I mean global north, right? But the amount of mortality that attributed to breast cancer is higher at this end compared to the other side, which have more people who have been diagnosed. That probably poses a question on where the screening might be lesser, or maybe how we manage or how people shows up later, we can't manage them properly because of the later stage. This emphasizes the importance of community ownership of this problem, right? Every member of the community need to be aware, and they need to be health smart in all array. And obviously the issue on integration, when a woman shows up in a clinic for ANC, is so important that we do all it thoroughly, right? But also now we have invented this community health worker. We provide them with those resources to at least emphasize people to really get to know their body very well, so that they can able to have that ability to seek care as the earliest opportunity that is available. Dr. Mary, we really appreciate you through Jhpiego for your support in the government, both mainland and Zanzibar. Without you, we wouldn't have this finding today. But also you are telling us there's a problem, and us as government, we need to really uptake it and sustain it. So we acknowledge that. But also most importantly for the Fraser, that has been part of this to facilitate what we have been doing. But we really need to appreciate both of our leaders, Her Excellency Dr. Samia Suluhu and President Mwinyi, for allowing us to really advance our healthcare in so many ways, especially focusing on women and children. There are a number of contrary issues such as costing. I do believe the government will oversee that by focusing more in universal health coverage, but most importantly here there are issues that are internal, right, between the departments of the hospital themselves. They really need to have proper thorough communication in order to improve patient outcome. That you really came out very well with that. But without further ado, if you propose to picture event, that's no problem. But I'm really privileged to be part of this podium today and sharing this insight, which is very important in our roadmap to tackle at least breast cancer. Breast cancer, if early diagnosed, can be prevented, and the community involvement is so important so that we can promote early detection, because that's the only way we can able to secure life of these mothers. There are some as early 20s, yeah, that seemingly to be a problem because there might be genetical link, there might be environmental trigger for that. So we really need to be aware there is no age limit anymore in relation to that. Without further ado, I would like to thank everybody who has spent their time to be here, and until we meet again, thank you all. Thank you.
Thank you so much. So this session is over. It was very interactive. So we can go for breakfast now. But at 10:30 we have another session here, Farm Access. Thank you so much, speakers, for your insightful session. Thank you so much. The next session is Farm Access at 10:30.